My name is Jordan Coleman. I am a third-year medical student at Texas A&M College of Medicine. I'll be presenting to you today case report, difficulty ambulating in young adults. This is a case-based review of non-specific MS presentations. So just a little background on multiple sclerosis or MS. It is the most common progressive neurodegenerative disorder affecting young adults. The pathogenesis of MS is unclear, although it's thought to involve autoreactive lymphocytes targeting myelin sheaths. Diagnosis currently hinges mostly on clinical imaging and laboratory evidence, demonstrating lesion dissemination in space and time. Patients often present gradually over time with symptoms like ataxia, asymmetric weakness, as well as visual disturbances such as optic neuritis. So in our case, we have a 25-year-old Hispanic female. She had a pertinent past medical history of gastritis and vitamin B12 deficiency. She presented to us with rapid onset bilateral lower extremity weakness, difficulty ambulating, and gait ataxia that was worsening over the span of about a day. At the time, she had no upper extremity defects, deficits now or in the past. She had family at bedside, and they also shared that she had a similar event about a year prior after consuming marijuana. She stated that this event occurred in under an hour and resulted in her experiencing total paralysis and being unable to walk, but self-resolved in under an hour. In a review of symptoms, she also shared that she had some arthralgias, paresthesias, hair loss, and brittle nails during these episodes. But besides her past medical history, her other history was largely unremarkable. Physical exams showed a little bit of lower extremity weakness bilaterally, as well as unsteady gait, but no other neurological symptoms at the time. When we were looking at her initial labs, they were largely undiagnostic. There was mild leukocytosis. Urine analysis showed 3+ blood and 1+ protein. She had an elevated INR as well as a vitamin D deficiency. From this, we ruled out the possibility of a stroke with a non-contrast CT, which was unremarkable. So as we continued to kind of look into the case and try to figure out what's going on, in our differential, we had a lot of autoimmune causes such as lupus, neuromyelitis optica, as well as vitamin deficiencies based on her past history of B12 deficiency, as well as because of her age and sexual activity, we considered infectious causes such as HIV and syphilis. Because of her atypical presentation and kind of uncertain lab, we decided to get an MRI with and without contrast of the brain, C-spine, and thoracic and lumbar spine. The MRI of the brain revealed over 30 active lesions. This was throughout the brain, thalamus, hypothalamus, as well as the cerebellum. The MRI of the spine also revealed multiple active lesions, as well as multiple inactive old lesions from C1 to T1. But interestingly enough, in her case, there were no lesions in the lumbar region found, either active or inactive. Based on the dissemination of time set by different age lesions, we were able to diagnose her with MS based on the McDonald criteria. Consulting with neurology, they recommended 5 days of high-dose steroids, which did improve her lower extremity weakness slightly, as well as some PT and OT. But ultimately, she was still ataxic at discharge, and we kind of referred her to a MS clinic for further treatment. We present this case as an opportunity to kind of share and recognize the symptoms of MS and increase the awareness of the disease's ability to hide with undifferentiated symptoms. Unlike what we consider to be the classic presentation of gradual onset of symptoms, visual disturbances, weakness, she presented very rapidly with rapidly worsening symptoms, and she had a history that could be attributed largely to possibly other things like vitamin deficiencies, marijuana use as well. When she finally did see us, she had extensive demyelinating lesions. This posed a long-term risk to debility. Her imaging kind of mirrored her unexpected presentation. She had no lesion in the lumbar spine, while having extensive active lesions from C1 to T9. Despite this, before this flare up, she had no deficit. She was walking around with regularity. So basically, to kind of sum things up, multiple sclerosis remains a complex disease. There is unclear pathogenesis, though we have linked it to prior EBV infection, low UV exposure, vitamin D deficiencies. Though it's often thought to be most prevalent in Caucasian women, there is newer data out there suggesting higher prevalence in women of color. These factors, along with her unusual symptoms, provide an important lesson for the workup of any patient with neurological deficits of any age or background, with symptoms like difficulty ambulating, gait ataxia, as well as weakness. Ultimately, it's a very challenging disease to diagnose and treat, but keeping MS in the differential of cases with undifferentiated neurological symptoms can greatly benefit patients long term. Steroids as well as some biologics have been shown to be promising in treatment of early MS and help to limit the relapse and flare-ups that some patients see. So that is my presentation. I'm happy to answer any questions.
All right. Thank you so much, Jordan. Just one question. You mentioned she had B12 deficiency. Like, how significant was that? Did she have any evidence of like a macrocytic anemia or anything going on additionally?
So that's a great question. Her CBC was largely unremarkable. She was normocytic. She had no macrocytic anemia. The B12 deficiency was diagnosed a couple years prior when she had had a previous flare up. She had a mild B12 deficiency at that time, and so she was given supplementation. She never had it repeat tested, but when she saw us, she had a normal B12 level, but just mildly decreased vitamin D, about 24, usually between 30 and 80 is what we expect. But our B12 was normal, no anemia, anything like that.
All right. Perfect. Thank you so much.
Thank you.
Please support our mission to improve quality of patient care through education. Join us, follow us, and share this content with family and friends.